Good morning, everybody, and welcome to this session hosted by the College of Public Health Medicine. So I'm Saiendhra, I'm the president of the college, and I see my dean here, so I should say I'm from the University of Pretoria as well. So the aim of the session is really to have our inaugural eponymous lecture of the college, which is called the Pholela lecture. But I think we were going to use this opportunity just to introduce you to the college, and I'm hoping that the slides will be loaded shortly. So the College of Public Health Medicine is a constituent college of the Colleges of Medicine of South Africa. And essentially, the Colleges of Medicine of South Africa is responsible for the exit exams of specialists, medical specialists being trained in the country. So for this session, we're following CMSA protocol, and that's why I'm wearing a tie. I was just telling Harsha, this is the first time I've ever worn a tie to a PHASA conference, but it tends to be mandatory for CMSA. So the mission of the Colleges of Medicine of South Africa is to sustain and improve postgraduate medical education and training in Southern Africa as an independent examining body, recognized both nationally and internationally. But it goes beyond that. It also is to play a role in providing guidance on issues affecting medical standards and the structure and function of healthcare services, and to remain an autonomous body for promoting and maintaining ethical and professional standards. So it consists of 29 colleges. So if you've been to see a medical specialist recently, they've likely received a fellowship from one of these 29 colleges. Not every specialist has a fellowship. Some of them have MEd degrees, but generally these days most graduate with a fellowship. So public health medicine is one of the 29. And I was just thinking it requires a lot of stamina to attend one of our admission ceremonies, to go through 29 different colleges. I know I'm a bit relieved when we get to the Ps, but then you still have pediatrics, pathologists, physicians, plastic surgeons, and psychiatrists before you get to public health medicine. In terms of the leadership of the Colleges of Medicine, this is our current leadership structure. So it's Professor Johan Fagan, who's an ENT surgeon, Professor Zach Cotto from the College of Surgery, and Professor Johnny Mshlangu from the College of Pathology. I think most of you know the immediate past president, who was Professor Flavia Sinkobuke. She's a former vice president of PHASA, and the first member of the College of Public Health Medicine to lead the Colleges of Medicine of South Africa, and also the first black female to lead the Colleges of Medicine. So we're very proud of her achievement from the perspective of our college. And then I think you're all familiar with Professor Eric Book, who's the Chief Executive Officer of the Colleges of Medicine. Just then a little bit about our college, Public Health Medicine. I looked at our constitution yesterday, and we've got about 32 duties and functions, but I'm just mentioning 3, which is to maintain and advance the standard of public health medicine and occupational medicine, to determine the curriculum for examinations of the College of Public Health Medicine, and to determine the scope and format of examinations of the College of Public Health Medicine. So that's our core function, is essentially assessment and examinations, but we do a lot of other stuff. And just to mention a few members of council, 2 of them are up here with me. Professor Tracey Naledi, who is Honorary Secretary, and Dr. Shrikant Peters, who leads our membership and career pathing subcommittee. and I'm not sure if she's here, but Professor Shaida Hadams, who's head of our Division of Occupational Medicine. And we've divided our work essentially into 5 subcommittees: curriculum and assessment practices for occupational medicine, curriculum and assessment practices for public health medicine, and that subcommittee is led by PHASA. Then evidence-based advocacy, and we'll hear a bit more about our work in terms of that from Professor Nandi Siegfried. Membership and career pathing, and then we have a committee of the registrar representatives. So in total, we've got about 227 fellows and associate members working across the health system. And fellows are people that have taken our exam and met our requirements. Associate members are colleagues that we consider having equivalent qualifications, like an M.Med degree in community health or public health medicine, or those that have received their specialist qualifications overseas. So we are working across the health system. Some examples: the NDO, National Department of Health. I don't know if he's here, but Dr. Nicholas Crisp is one of our associate members. Provincial Departments of Health, a very strong presence in the Western Cape, where our specialists have been doing good work for a number of years. More recently, we have established a presence in Limpopo. So beyond what Poppy Ramatuba says and does, there's some public health medicine specialists doing very good work there behind the scenes. The districts, presence in the Cape Metro and in the West Coast, and in Gauteng, in Ekurhuleni and in Tshwane. Then NIOH, obviously, where we have a lot of occupational medicine specialists. We also have public health medicine specialists there, like Prof. Muzi Zungu. NICD, I think people have become familiar with Dr. Wasila Jassett during the COVID pandemic. OHSC, we've got specialists there. Tabiso Makula, who's around, is one of those. So yeah, we are doing work across the health system. I think we can make a bigger contribution, and we're trying to create those opportunities. Obviously, there are specialists in academia and in the private sector as well. And then my last slide, just in terms of the relationship between the college and PHASA. I should note that 4 of the last 5 PHASA presidents are fellows of the College of Public Health Medicine, including the current president. And I think it was just Moketsi that broke the sequence, who was between Andre and Ahasha. And then we also have PILA award winners, Prof. Leslie London, who's head of public health medicine at UCT, Professor Eric Book, and then Professor Maila John Majila, who was head of department at UP. So just a brief background there on the college. I think we're just going to move straight ahead, which is to highlight some of the work that we've done with respect to evidence-based advocacy, and I think that would be most relevant and pertinent to this audience. And the person that's going to talk is Professor Nandi Siegfried, who led our task team that worked on guidance documents at the early stages of the COVID pandemic. So just quickly, a bit about Prof. Siegfried. She's a fellow of our college, obviously, and works as an independent clinical epidemiologist in Cape Town. She holds an MBCHB from UCT and an MPH from Sydney University. Between 2003 and 2007, she was a Nuffield Medical Fellow at the Clinical Trials Unit at the University of Oxford, where she also has a doctoral degree from. Previously co-director of the South African Cochrane Center at the MRC, and currently a part-time chief specialist in their health systems research unit and alcohol, tobacco, and other drug research unit. She served as a facilitator, chair, and technical advisor to over 25 WHO guideline development processes mainly in HIV and prevention and more recently in COVID-19. And she's an honorary professor at UCT. We're very glad that she was around to lead us in terms of this initiative. Nandi, over to you.
Thank you very much, Saiendhra. What is the protocol for me? I didn't bring a tie.
Yeah, I think there's actually no protocol for them. They can do anything they want, Tracey.
So I'd like to start with thanking the college for giving the task team an opportunity to present our work to a broader audience. And I'd also like to thank the Medical Research Council's Health Systems Research Unit, who supported my attendance at the conference. I'm going to speak about the why, the who, the how, the what, the when, and importantly for this group, the so what and the what now of the work we did earlier in the pandemic. I'm going to talk about the need for establishing a task team, who was on that task team, what our terms of reference were, and then explain how we developed our guidances. I'll show those to you very briefly, the guidances in public transport, school health, masks, and rational testing. Then go through the timeline of the guidances, which when we put this together, I look back at and I'm quite amazed at what we managed to achieve in a short period of time. And then I'll look at the impact using our school health guidance as a case study, and then finally just some considerations about what this means for the future. So I'm sure most of you in this room are familiar with the evidence ecosystem. I don't know how I can use a pointer, so you'll just have to start on the left-hand side with where we produce evidence. That's where we use primary studies. If we're looking at interventions, primarily controlled trials, if at all possible, to determine whether something is effective or not. It then moves through a process where we can pool that data from different studies in a systematic review with sometimes meta-analysis. And then we get to the knowledge translation part, which is when we use that evidence to develop policy and guidelines. And then you go through dissemination, implementation, and evaluation, leading back to where the research gaps are and where we need to do more primary studies. So let me take you back to that fateful day on the 5th of March, 2020. I'm sure all of us had tremendous concerns for ourselves, for elderly relatives. I personally was watching what was happening in the school environment in the Northern Hemisphere, and day by day becoming increasingly anxious because I had a daughter in matric, and for me, I knew that those schools had to stay open and stay open safely. So I approached Leslie London, and this came about because I was looking for guidance for schools. My daughter's school had reached out to me about what they should do in preparation for when they had their first infection, and really there was little that I could find, even internationally, to be honest. So there's no central structure at the moment in South Africa where public health guidelines are actually developed. And NICD, particularly in the early part of the pandemic, were focused on case identification and contact tracing primarily. And there was a lot else to do and resources were slim. So we recognized that there were gaps in public transport, school, travel, and public population, general population prevention tools like masking. And Leslie and I spoke about having a moment of opportunity to provide evidence-based guidance to the government and public. And just for those of you, I know Saiendhra mentioned it, but Prof. Leslie London was president of the College of Public Health Medicine at the time. So who was involved? The task team in the circle are all featured there from around the country. You'll see the College of Medicine executives. Saiendhra already alluded to them. At the time, Eric Buch was CEO, Leslie London was president of the College of Public Health Medicine, and Flavia was president of the actual college. And as Saiendhra said, interestingly enough, they are all fellows of the College of Public Health Medicine. Then at the bottom is a long list of systematic review authors. As you all know, systematic reviews form the foundation of good evidence-based guidelines. And it takes effort, commitment, and usually a lot of time to do a systematic review. But those individuals worked tirelessly to conduct what we call rapid reviews, and they came from the Health Systems Research Unit at the MRC, from Cochrane South Africa at the MRC, from Prof. Taryn Young, also a college fellow at the Center for Evidence-Based Healthcare at Stellenbosch University, as well as colleagues from overseas, including McMaster University in Canada. So we decided we'd have a small group of approximately 8 fellows. The college felt it was important that we had some national representation. A couple of us in the Western Cape had already got together. And so we asked for volunteers from all university departments where registrars are trained. And we decided we would meet weekly. We would review the current data and share additional intelligence that members might have, identify key questions for which guidance is necessary, and prioritize questions for urgency and feasibility. We would identify data sources to appraise for their methodological robustness related to those questions, and where possible, have a rapid review conducted where those key results would be synthesized, and then we would develop headline summary guidance. We would draft that guidance to be circulated to the fellows, and at least 6 of them needed to, not the fellows, the council of college, and at least 6 of them needed to approve, and we gave them a very generous time period of 48 hours to get back to us. And importantly, we wanted to disseminate this to the public as independent guidance, and that it would be relevant for the wider community too. Before we started, we developed some principles, the first being, first do no harm. This principle was thrown out of the window at the beginning of the pandemic. Very often, urgency, emergency situations compel us to want to do something. Often, doing nothing, waiting, observing, watching is a safer option. Many mistakes were made, and I don't have time to go into that today, unfortunately. Our principle was to look at the overarching benefits and harms from the systematic reviews whilst acknowledging uncertainty. This brings me to the very important point that evidence is essential for guideline making, but it's insufficient. We need to consider other factors, transmission dynamics, social, cultural, behavioral factors before you can actually make a guideline. We want it to be systematic and be transparent, avoid duplication at all costs, and of course, as I said earlier, be independent and non-aligned. One of the things we did was develop a prioritization tool where we asked about whether there were other guidelines which we could lean on, other studies that we could use. But we tried to look at prioritizing, which was consensus-based. How big a priority is this for South Africa right now? And then as we went along, we added longevity into this process because we wanted to do things that would have legs beyond just COVID-19. How did we make our decisions? I think this is something that is perhaps the most important that came out of our experience. We used the GRADE approach. GRADE has been around for approximately 20 years. It developed out of the Cochrane collaboration with the knowledge that systematic reviews are rarely read in their entirety because they're long. And you really need some headline summaries. And it allows one to assess the overall certainty of evidence arising from a systematic review. And it has a transparent, systematic way of making your decisions using that evidence and considering other factors too, which I'll show you in a moment. Importantly, this is used internationally by many, many healthcare associations. The WHO started using it in 2008. It forms the bedrock of their guideline development process, and you are able to download this book from their website, and it's very helpful. What is it about GRADE that makes it special? It uses an evidence to decision-making process where you balance the benefits and harms and the certainty of evidence. And that information comes from systematic reviews. But then you also look at other factors such as values and preferences, resource use, feasibility, foregrounding equity and human rights, and acceptability. And those factors aren't weighted. So again, while evidence is essential, it's insufficient for making a decision. I'd just like to, I'm going to have to go a bit closer to read this. In May Russell Rensburg, who's the director of the Rural Health Advocacy Project. So we've been going since March, this is May. What we should be focusing on is what is government's process and how can it be improved? Because at the moment we're in uncharted territory. How do they achieve decisions as a collective? How do they record dissenting views? On what basis do they pass the regulations? Rensburg asked. I'm still in the dark, 2.5 years later, as to how those processes actually worked. So what did we do? We produced a guidance for public transport. That was something that Eric Buch initially said we need to, in those first few weeks, we need to give people guidance about what to do getting in and out of public transport. Our guidances are 2 to 3 pages. They summarize the evidence of the time and then go through how we made our decisions, as well as key pointers based on public health principles about what can be done to keep people safe getting in and out and being in a taxi. We also looked at masks, cloth masks, medical masks, schools, and then lastly, rational testing. Let's look at our timeline. So, the 5th of March, COVID arrived in South Africa. We convened the task team on the 13th of March, and then we spent a few days, and this was very important, developing our principles, our terms of references, and how we would make our decisions. We then brought out almost immediately a College of Medicine media statement. Our media statement said nothing more than that we exist and we're going to be producing guidance. Media was very interested in everything COVID related at the time, and we wanted to put ourselves out there as individuals, as a team who could be contacted to provide input into the media. Schools closed the day later. So, hey, I was also doing online school teaching, so I had lots of time on my hands. And then a couple of days later, we brought out this public transport guidance. And the individuals who did the rapid review turned it around over Friday to Monday. It was really quite amazing. Lockdown a week later, then we went into cloth and medical masks. We prioritized cloth masks because we were looking at general population interventions. And then schools, and finally we looked at rational testing. So what? Let me look at school health. So school health guidance was produced, I think it was in April. We were invited shortly thereafter to input into the Ministerial Advisory Committee's technical working group. Continued to do that until the beginning of this year, in fact, and those took place on an ad hoc basis. Importantly, we developed a relationship with the Department of Basic Education nationally and assisted them with reviewing and structuring their standard operating procedures, and the initial ones certainly borrowed very heavily on our guidances. We got involved in a living systematic review, which is updated continually, globally, looking at the risk of transmission in schools to children. And I'm delighted to say we recently finished a very small pilot feasibility study of school transmission in the Western Cape. So we developed a relationship with the Western Cape Education Department. I don't know if Hassan Mohammed is here from the Western Cape Department of Health. They put together a monthly meeting between education and health, and out of that we were able to actually do this study. Many of the schools and the various associations who used our guidances produced lovely infographics. That's the keep mantra, which Jim Vartanodia on our task team put into the end of the school health guidance, and they made it look a lot more visually appealing. We were invited on one occasion to be part of the Scientists Collective to input into the Daily Maverick series about a 10-point plan for keeping schools safe. And then with Professor Mary Metcalf from the Wits Department of Education and Prof. Shabir Mahdi, we were asked to assist with allaying fears, doing webinars for teacher unions before the schools reopened. And we did many, many of those. We were also asked to engage with the NGO Equal Education Law Centre on several occasions. There are actually quite a lot of legal questions which remain open, particularly around isolation, quarantine, and so on and so forth, that we really need to grapple with now, because actually nobody really knew what the right thing was to do. And then finally, many of you who work in universities will know that Higher Health produced all the guidelines for the post-school education training sector at the behest of the Department of Higher Education, and our task team reviewed those guidelines. So let's get back to the evidence ecosystem. It was really here that the task team was operating, both from synthesizing the evidence, translating it, and disseminating it. So what? Why did we work well? I believe we were nimble. I think many people were at the time. We worked with zeal. We really wanted to contribute. And we also knew it was time-bound. We hoped it was time-bound. We knew we wouldn't be doing that forever. But I think primarily everybody on the team had a very deep understanding of public health principles, that these are inclusive not only of science, but of culture and belief systems. It was also very simple things like understanding the hierarchy of infection prevention and control and so on. I believe it was essential that we spent a few days developing an a priori structure for the work we were doing, and that our decision-making was based on international norms and standards. It was voluntary, but we tried to be as representative as possible of the national reach of the College of Public Health Medicine. And we were really in the thick of it at times, but due to our group cohesion and because we'd really grappled with the evidence, I believe we were able to be quite resilient in the face of, at times, enormous political pressure, both from fellow scientists, fellow researchers, fellow public health professionals, and of course from the government. And lastly, I think the fact that we were independent was extremely important, and we had the stamp of credibility coming from the College of Medicine. But we lost the debate before it even began with masks. Enough said. Rapid reviews are the foundation of evidence-informed guidelines and policy, and they require enormous commitment. And people were getting tired after a few months. It just simply couldn't continue at the rate it was going. We had no formal avenue for contributing to the national discussions, as in the MAC, and we were very reliant on our personal networks to try and get those guidances seen by people who were making those decisions. So we really had no true seat at the table, and there was an absence of public health professionals, we know, certainly at the beginning. I don't know how many of you know that a lot of this was thought about already. In 2015, the Academy of Science of South Africa brought out a report, The State of Biosafety and Biosecurity in South Africa, and it was really looking at how well we managed outbreak control. And part of that, I interviewed key stakeholders from all the players, all the leading institutions in South Africa about outbreak control. And I think it's worth seeing that this statement about strengthening human research resource capacity at all levels, addressing shortcomings in current legislation, which remains, increasing the linkages between laboratories and the current disease notification systems, and formalizing communication structures between government and research institutions will improve the implementation of national strategies to manage disease outbreaks. And particularly this point about many people saying that outbreak control was done well, but it was due to personal networks. And I think that this is a big gap in South Africa, that we don't have a lot of this formalized. But you will all be aware that the National Public Health Institute of South Africa was passed into law in 2020. And I've scrutinized it. I scrutinized it before it came out and took part in the public participation. And it is really extremely quiet about evidence-based anything. There's a little bit in the preamble. I draw your attention to the second bullet, restructuring and transformation of the public health sector to provide evidence-based leadership in public health services and to serve as focal point for the efforts to protect and improve health. And I'm delighted to say that the reason why it's useful to come to conferences like this is that yesterday I discovered that Dr. Atiya Musa, where is she, also a fellow of the college, has just been tasked with providing technical support to implementing NAPISA. And so I'm delighted to see that we've actually got movement. And perhaps the fact that it's broad like this means that there will still be room for knowledge translation. So what do I think about the future? It's important to say that College of Medicine of South Africa and the College of Public Health are not in the guidelines business. This isn't core business, and you didn't see it when Saiendhra presented what we actually are supposed to do. But I think it filled a gap, and it really demonstrated a proof of concept, if you like. we require a national structure to look at public health guidelines. Central drug list, users grade, they go through this process, it's already embedded to some extent, but not for public health guidelines. I believe we need a clear separation between outbreak control activities, which sits squarely with NICD and other public health measures. As I said, NAPISA is silent on knowledge translation and guidelines. That might be a good thing. We might have an opportunity there to influence that. We all need to continue with advocacy for evidence-based structures within all of our institutions. And then just to conclude, I've been hearing this a lot at this conference as public health professionals, both college and non-college public health professionals. We need to claim our space. And one of the ways of doing this is to have a strong media presence. And if you recall, right at the beginning, we produced this media statement, and we also asked members of the task team to be available to the press. And Dr. Karen Begg agreed to be our official spokesperson. And if any of you go onto YouTube and you just type in Karen Begg, you will see pages and pages of videos of her speaking to the press. And I'd like to conclude with a statement I found when I was going through all of this that Karen made. We cannot miss the greatest opportunity that the pandemic provides us with, which is to build a universal healthcare system where we can truly deliver health for all. Thanks for your attention.
Thank you, Nandi. I think sitting on council at the time, I think we were truly impressed by the turnaround times of this high-quality, evidence-based guidelines. And really, there are a number of lessons, and I think there would be a number of questions, but we are running out of time. If there's time at the end for a Q&A, just save your questions, or maybe have a chat with Nandi after the session. So we're going to move on then to, as I said, the main aim of this particular session, which is our inaugural Pholela lecture. And I'm going to call upon Dr. Shrikant Peters, who, as I said, heads our membership and career pathing subcommittee, and they're responsible for the Pholela lecture, to give you some background as to why we chose Pholela as the name of our eponymous lecture. Shri?
Can I just get the slides up? Okay, I'm going to put this down for myself. Hi everyone. Thank you very much for attending our session. My name is Shrikant Peters. As you've heard, I'm the chair of the Career Pathing and Membership Subcommittee of the Council of Public Health Medicine. It's my great pleasure to introduce the topic, and then followed by me will be Prof. Naledi introducing our speaker for today. In discussing the name of the lecture, we went through quite a rigorous process in the college, where we had a short listing of options available. People in the college, people who have passed as specialists of public health medicine, both living and not. And we settled on Pholela. And the reason why we settled on Pholela was for the symbol it stands for. And I'd like to take you through the description of that symbol, what it means to us. Often in public health, and you've heard it at this conference, we are prone to despair about the world that we live in and the fact that we have not achieved the goals that we would like to in our lifetime. But I would encourage you and remind you that we are looking at big systems, the big picture, and it does require us to delve into our history, which is what we're doing today. So, in terms of South African history, big picture article was written by Kuvadia et al. Describing the different time periods of our country, starting with the period of colonization, where the Dutch established their refreshment station in the Cape and eventually lost it to the British in the early 1800s, which obviously precipitated the Great Trek east and north through the country, eventually finding gold, a rapid economic expansion in the country at that point, and then the First and Second South African Wars in the early 20th century. Finally, in the early 1900s, we see the 4 states proclaimed as a union of South Africa, as a self-governing dominion under the British Empire. That was from 1910 to 1961. But of course, in 1948, we had the imposition of apartheid, where the Conservative National Party won an election based on the concept of swart gevaar and the things we should fear about being a diverse, unitary nation. They also banned a majority of African liberation movements, including the ANC. For most of us, and a very few who are not able to remember, we achieved democracy in 1994, a new anthem, a new flag, a new sense of purpose and being with our first democratic elections, with sweeping changes to government structures, priorities and policy. Now what Kuvadia et al. Does in his article, does in their article, is also describe the history of the social determinants of health in the country through those ages. In the time of colony, we had the diseases of poverty and displacement, smallpox, measles, malaria, the fledgling alcohol and tobacco trade, which were not able to penetrate Fortress PHASA this year. We had farming and mining and all the diseases, occupational, environmental health that go with that, and the DOP system and tuberculosis. Under Union, so we had an intensified labor migration and increasing dislocation of family life, which we still see today. Poor urban and living and working conditions with limited rural access to healthcare. And in this environment, we had Sydney and Emily Clark, 2 medical graduates from WITS, piloting the community-oriented primary care as we know it today at Pholela in 1940. We know apartheid commenced, but just before that, the National Health Commission of the Union was established based on principles in the fledgling National Health Services of the UK. And they had recommended a unitary community healthcare-based system. Shockingly, the findings were discarded as too expensive to implement primary healthcare. And so we saw the development of a tertiary biomedical focused model, and the unequal access to healthcare is continuing from that, and obviously within the spheres of public and private healthcare. Under democracy, however, the new government did adopt the PHC approach, providing primary healthcare free and hospital-based care on ability to pay. And they just devolved responsibility of healthcare service delivery to the provinces. What is very interesting if you look back at our history is that the terms national health insurance was first mentioned in the SAMJ of 1935. That was the first time anyone had heard of the NHI. Henry Gluckman, the commissioner in charge of the Health Services Commission, had said, "We agree that unless there are vast improvements in the nutrition, housing, and health education of the people, the mere provision of more doctoring will not lead to any improvement in public health." Now, Sydney and Emily Clark had testimony at that commission where they described the centre at Pholela, where they developed community integrated healthcare, which increased personal agency, included demographic analysis of defined geographic regions, screening, the building of pit latrines, founding of vegetable gardens, and documenting the social determinants of health, including migrant labor and community food production. They said that hospitals were costly monuments to the failure of adequate preventative health services. Unfortunately, disillusioned with the politics of the day, Sydney and Emily Clark went on to Israel and the US, where they established the fields of community health and social epidemiology there, and George Gale, their mentor, when the funding was pulled for the Community Health Centers Initiative, and after he became Dean of the University of Natal Medical School, absorbed the Cox Institute into the Child and Family Health Unit in the University of Natal. As you see there, some of the quotes from the time included that the doctors of the time paved the way for apartheid medicine. Despite their awareness of the social causes of disease, they continued to advocate for purely a medical response, while social policies they saw as necessary for improvement were left unimplemented. Sidney Clark says the community's etiological concepts constitute an intrinsic element of the program he was running, because ultimately it is their concept which provides the motivation for action. And finally, from George Gale, the previous Dean of the University of Natal Medical School, change in the healthcare system cannot develop out of a program solely limited for the poor, because once it becomes simply a project for the poor and powerless, it can be dismantled far more readily. And so we've decided on the topic of Pholela as a symbol. In public health, we're taught in epidemiological terms to think of the concept of the counterfactual, and what outcomes we would get if we had different input factors. Pholela for us is a symbol of a counterfactual history of how the world would have developed, how public health in this country would have developed had we engaged with the model of Pholela. It's not just a time to despair, it's a time to think of the counterfactual future that we're trying to build based on the decisions we make in this room and our places of work as we head out of the conference today. That's the topic of Pholela. I will now leave it to Professor Tracey Naledi to introduce our speaker for today. Thank you.
Thank you, Shri. Mine is to introduce our inaugural lecturer for today's Pholela lecture, and it is Professor Lilian Dudley, who is a public health medicine specialist, Emerist Associate Professor, and previous head of the Division of Health Systems and Public Health in the Department of Global Health at Stellenbosch University. She has provided leadership in public health policy, planning and implementation in various capacities at local, national, and international levels over the last 3 decades. Her research has focused on health system strengthening and quality of care, particularly for TB and HIV, health information systems, capacity development of health professionals and managers in low and middle income countries, and research evidence synthesis. Throughout this conference, many have referred, and I think that one of the themes that has prevailed in this conference has been honoring those who have come before us and the giants on whose shoulders we stand on. And in the first plenary in the conference, Profs Abdul Karim's honored their mentors, Profs Sasa and Stein, by contributing to the lecture that we had on day one, and really honored them for the contribution that they made in terms of developing public health in South Africa. And we believe that Lilian is certainly one of those colleagues who has also contributed to building the discipline of public health in South Africa. Prior to her tenure at Stellenbosch University, she was the CEO of Health Systems Trust, a leading national health NGO in South Africa, where she was the first Black woman CEO. She spent the several years as a senior manager of health services in local and provincial government in the Western Cape, and she has served on various national committees, including the chair of an ASAF panel established to review governance of the South African health system, and was a member of the National Lancet Commission on Quality Health Systems between 2017 and 2018. She was the past president of the TB Alliance Support Association and was in fact also the past president of the Epidemiological Society of South Africa, which was the precursor for PHASA. And she was the founding president of PHASA back in 2000. She served on the board of the Health Information Systems Program and was the member of the Council of the Public Health Medicine of South Africa, and our colleague, and actually chaired one of the subcommittees, which was the Medical Management Subdivision. So those of us who've been on PHASA board and who've been on the council, I certainly have encountered her name. You'll see it when you look at past documents, both within PHASA or within the college and the council. You'll see her name appearing in many of the documents, in some of the founding documents of these organizations. She is the member of the TDR Scientific Working Group and Committee on Postgraduate Training, and was the fellow of the Takemi International Health Program at Harvard Chan School of Public Health, which she has continued association with and has served on international bodies, including WHO committees for TB, primary health care, and health systems research. So, like Prof. Glenda Gray, in the opening of the conference in the reception, Lilian unfortunately has COVID and has been stuck in her room throughout the conference and has missed most of the conference. We were hopeful that maybe she could join this morning, but she will be joining us online. We are eternally grateful that she is here today online to deliver the lecture to us. Lilian is certainly a tireless cadre for public health, and we are very, very honored that she's accepted our invitation to be our speaker in this inaugural lecture. Ladies and gentlemen, please give a warm round of applause for our esteemed colleague, Lilian Dudley.
Colleagues, I can't really see the visuals. I hope that you can see and hear me. I'd just like to thank my colleague, Prof. Tracey Naledi, for that very generous introduction. Yes, it's hard to recognize oneself when it's described in such flowery and beautiful terms, but thank you, Tracey. And then especially to the College of Medicine of South Africa for inviting me to contribute to this session. And it's also really wonderful to see how visible the College of Medicine South Africa is at the PHASA Conference and the role that it's playing. And then also to PHASA Exec for including me on the program. And as Tracey has said, I've unfortunately been waylaid by COVID, just as we thought we were moving post-COVID, it sort of snuck up. And I haven't been able to participate in any of the sessions, that have been incredibly disappointing because the program has looked absolutely fabulous. It's really incredible to see excellent research is happening, and that has been presented at PHASA, and the platform for networking and sharing is really an important one, so congratulations again to PHASA for providing this forum. I've been told that the network is a bit unstable, so I'm actually not going to be doing my presentation directly. We've recorded it, and it's not perfect, unfortunately, to have a recording, but I do hope that you will find it interesting and useful. I'd like to thank Shrikant Peters for giving that really good introduction about Pholela. And hopefully the story that I'll be telling in the presentation picks up on the background that he has given. There may be a little bit of overlap, but I'm really in my presentation looking at how Pholela has influenced developments in South Africa around community-based care and where we are at the moment, and some of the opportunities for public health going forward. So thank you very much, everybody, and I'll sit back and also listen to the presentation, and hopefully we can have discussion later.
Good morning. My name is Lilian Dudley, and I'm an Emeritus Associate Prof at Stellenbosch University. I'm very honored to be giving this Pholela inaugural lecture today, and would like to thank the College of Medicine of South Africa and PHASA for giving me this opportunity. So the talk I'm going to give is really going to make use of the focus on Pholela and to try and trace the development of some of the initiatives from Pholela through to our current health system. As background, just a few words about Pholela. In the 1940s, a young couple, Sydney and Emily Koch, who were doctors, moved to rural KwaZulu-Natal to a place called Pholela, where they established a health service model which was very innovative at the time. And they were followers of the social medicine approach, which really looked at health as being not just an individual concern, but really part of the health and the well-being of a group as a whole, so the social aspects of medicine. And the particular model that they developed became known as community-oriented primary care, or COPC, which is a continuous process by which primary health care is provided to a defined community on the basis of its assessed health needs by the integration of primary care practice and public health. Some of the public health approaches that they incorporated were, first of all, the focus on the community as a whole and how factors in the community contributed to individuals' health. That clearly meant that they looked at the social determinants of health, even though they didn't call it at that time. They really looked at the environmental and other conditions which people were exposed to, which contributed to their health. They used epidemiology, one of the foundations of public health, as well as qualitative research methods to diagnose the health status of the community and to identify factors which contributed to the health status of the community. Using that information, they then developed, implemented, and evaluated interventions which sought to address the leading causes of disease in that particular community. In order to do all of this, they engaged, trained, and supported a multidisciplinary team of health workers to respond to the community health issues. And key in that team were the health assistants who were recruited from the local community and trained in that project, and then took responsibility for a certain number of households that they visited regularly, initially to obviously meet the families, but then also to obtain demographic and health status information, which was then used to look at the population, the health problems in the area, and also to be able to respond to those particular families' needs. They provided health promotion, health education, and basic health care in the community. The project also focused on community participation, so at its commencement there was engagement with leaders in the community to gain access, and in doing community diagnosis and developing interventions and implementing ongoing engagements to give feedback and to get input from the community. Some of the results which Sydney and Emily Koch presented showed quite impressive improvements. On the left, a chart of weekly weights of infants under 1 year old between two time periods. So the solid line is from the 1940s, 1941 to 45, and the dotted line at the top is from the 1950s. So you can definitely see a gap there. And the table at the right shows changes in the incidence of syphilis in the Pholela area over a similar time period. So with the successes that they were able to demonstrate, and Sydney Koch also became an advisor to the Gluckman Commission, which had been established to review the state of healthcare in the country at the time. And some of these experiences at Pholela then informed some of the recommendations for the national health system. And a key amongst that was that community health centres would serve as the basic unit of comprehensive service delivery in this national health system, which would cater for all the people in the country. Based on that, a further 44 health centres modelled on Pholela were established around the country and began to function, providing a similar community-oriented primary care service. Unfortunately, that was fairly short-lived, because in 1948 the National Party came to power in South Africa and did not support the recommendations of the Gluckman Commission for a National Health System. The political support and financial support for the COPC model and the 44 sites therefore diminished to the extent that the COCs and other COPC advocates eventually left the country. So there were these external factors, but there were also a number of internal factors, both administrative and also in terms of the quality of the work that was being produced at several of these centres, which were critiqued at the time and clearly gave people ammunition to undermine the centres. So the centres essentially then became purely curative services. The community components, the prevention, the promotion, all stopped. And in the words of a politician who crudely described it as inexpensive clinics for the early treatment of disease among natives. So really trying to keep people out of hospitals by giving them, the basic minimum care that could be provided. The rest of the health system then became racially segregated and continued to focus on hospitals. But at the same time, the government supported the growth of the private sector to meet the needs of the growing white middle class. And this particular arrangement persisted for several decades, which meant that the vast majority of the country had very poor access to health care, certainly at a primary care level and also in terms of higher levels of care. Towards the end of the apartheid era, and also overlapping with the era of the Alma Ata Declaration on Primary Health Care, many civil society organizations began to develop primary health care projects with community health workers, providing support in communities. And these coalesced ultimately into the National Progressive Primary Health Care movement, which provided very, very important lessons in terms of experiences with primary health care and how these projects could actually contribute to health in the community. These became important sources of information for the ANC National Health Plan, which proposed a health system based on the primary health care approach. And this was then translated into policy, firstly in terms of the white paper on the transformation of the health system. Subsequently, the government set about restructuring the entire health system to try and reduce fragmentation and move to comprehensive services. And a lot of attention was focused on expanding access to services, so building new clinics and revitalizing hospitals at the same time. Many challenges in the process of reducing fragmentation, both in terms of different political interests of the different departments, and essentially the whole process took much longer than I think government or anyone else could have anticipated. Other obstacles, human resource challenges along the way, and then the burden of disease. The growing HIV epidemic also demanded a lot of focus during that time period. And ultimately what it meant was that the prevention, promotion and community aspects of primary health care were largely not implemented. And where there were community health worker programs, they were really dependent on the particular civil society organizations to sustain them. So much of the intention of the initial policies and plans were lost in that initial period. And South Africa was criticized for the lack of improvement in health. And in fact, some people claim that healthcare worsened for the poor in South Africa as well. So Dr. Adam Naledi, when he became health minister in 2009, adopted a new 10-point plan which refocused the country on the primary healthcare approach. He also dusted off the national health insurance proposals to try and begin to look at issues of equity in healthcare between the public and the private sector and other ways, and adopted a new program of re-engineering of primary health care in 2011. One of the three main streams of the re-engineering of primary health care was ward-based outreach teams, essentially community health teams led by a nurse who would actually work in the community and link the community with the health facilities. So these were implemented in 10 pilot districts around the country, and some of the ward-based outreach teams actually reached back to the old COPC models and decided to use those as the basis for their work. So before we describe what has happened in these sites, let's look at the evidence for community-oriented primary care, given that outside of South Africa it gained a whole life of its own, and in the States and Israel, elsewhere, it had been adopted, and in the States in particular, it's part of the training of health professionals. The American Public Health Association produces guidelines on COPC, so it's very integrated into teaching and practice in many areas. So is there good evidence? A systematic review in 2008 did not provide any evidence of effectiveness, but was subsequently critiqued because it did not include community health worker programs that were not described as COPC. So it was very strict in terms of what types of interventions it included. But it did include a lot of the COPC education, so training of health professionals. So there was some concern that it didn't really reflect what COPC was focusing on in the communities. Other systematic reviews, in particular the Cochrane Review of Community Health Worker Programs by Lewin et al., which has been updated a number of times, has provided evidence of effectiveness for aspects of maternal and child health, immunization, for TB care, for HIV. So there is very sound evidence to support the practice of community health workers. Effectiveness of home visits for maternal and child health, the model that Olds implemented in the States of nurse visits for maternal and child health, was replicated in South Africa by Mark Tomlinson and Katzen in the Western Cape and Eastern Cape, and was shown that home visits by community health workers contributed to improved maternal and neonatal outcomes. These were not as dramatic as the improvements that Olds had reported, but certainly there were improvements. And then from the ward-based outreach teams, the Northwest site conducted a plausibility evaluation a few years ago. So when we say a plausibility evaluation, you can't establish causality absolutely, but it is plausible that the intervention contributed to whatever effect if shown. So this was a before-after study with a comparison to sites that did not have ward-based outreach teams, and they were able to demonstrate that there were improvements in the routine indicators for measles immunization coverage and couple year protection, and that there was a decrease in diarrhea or severe diarrhea in children under 5 years of age. Another study in Kenya of COPC, also a similar study design model, showed broad-ranging effects or benefits of the COPC to antenatal care, health facility deliveries, as well as water use and a number of other areas. So what is the current status of COPC in South Africa? The Human Resources for Health Strategy reported that there are currently 54,000 community health workers in the public health system as of 2019, and they represent a substantial proportion of the primary healthcare workforce, almost 50%, and 22% of the total health workforce, so not insignificant at all. Estimates were made by Bennett et al. From the Tshwane Award-Based Outreach Team's research that the country as a whole would need 7,800 outreach teams. And this kind of information has then assisted in some of the modelling. Emmanuel Daboud at the MRC has done a costing of community health workers as part of the re-engineered primary healthcare system to see what the country needs to budget, how it needs to plan. And Bennett, in another study in Tshwane, also showed that the ward-based outreach team interventions had a benefit-cost ratio of 3.4. So the benefit exceeded the cost by 3.4, and that there were net savings in the averted clinic and hospital use. So not only benefits in terms of outcomes in health terms, but also savings for the health system. So with the political commitment to ward-based outreach teams and a lot of the evidence, community health workers and ward-based outreach teams were eventually formalized within the health system in 2018 with the development of a policy framework and strategy for ward-based primary care outreach teams. The training was updated to move from purely disease-focused to comprehensive training and standardized to ensure that community health workers coming from different backgrounds all received the same training, and was accredited with a national community health worker curriculum was accredited. A community health worker unit was established in the National Department of Health, but the responsibility for designing and implementing the specific ward-based outreach teams was delegated to provinces, so more delegated, decentralized decision-making on this. The policy framework outlined the scope of work of the ward-based outreach teams, very broad, from health promotion, primary prevention of disease, health behavior counseling, treatment adherence, screening, referral, basic therapeutic rehab and palliative care, and gave them the brief to cooperate not only with healthcare facilities but also other government departments, NGOs and community structures. So what can we learn from projects that have been implemented in South Africa and elsewhere? Quite a few of the ward-based outreach teams have conducted evaluations in South Africa, and many of them have been included in a scoping review of COPC by Mash et al., which was published in 2019. So some of the lessons from these included issues around the building blocks of health, in particular around governance and leadership. Projects felt that this was absolutely critical, not just for the establishment of the COPC programs, but for the ongoing, for sustaining and ensuring their longevity. And they complained about this lack of ongoing political commitment, also about poor cooperation between levels of government, poor intersectoral collaboration, and there was a lack of understanding from managers about COPC and the ownership of COPC, with a very centralized leadership style coming particularly from the health services. Financing, an ongoing issue both for community health workers' salaries, but also for supervision support, and then for the supplies, transport and data management, which may not seem like critical components, but really played an important role in ensuring that these projects actually functioned. In terms of human resources, in many areas, professional nurses were not available to be the outreach team leaders, and in many areas enrolled nurses then took that role. And I think that's become more of the norm now. The retention of community health workers is a general problem and has been throughout the life of many community health worker programs, largely because of the insecurity of employment, the low salaries, the part-time employment, the uncertainty about contracts, and the lack of benefits. The projects also indicated that there were concerns about the competencies of community health workers, most of whom had come from vertical programs, particular disease focus, and now had to become more comprehensive and include prevention and health promotion. And most of them felt that they needed stronger management and supportive supervision for the community health workers. In terms of service delivery, the links with the formal health services were sometimes contentious, where clinic staff were often reluctant to integrate COPC. They felt that would increase their existing workload, and in other places saw community health workers as an extension of the clinic rather than recognizing their broader role in the community. Information and evidence. There were challenges in many areas with routinely collecting quality data, analyzing it and using it to inform decision making. So even though there were many innovations in ways of collecting data, like digital tools, very often it took a while for those to actually start working and for the data to become usable. And then the limited evidence of effectiveness. And that was very specific to this scoping review, because only one of the projects that had been included had conducted an evaluation of effectiveness. And then lastly, community participation and engagement. The community health workers expressed some concerns about their ability to access kind of support and the resources that the community might want, and there were some tensions around expectations and therefore acceptability in the community if they were not able to meet some of those expectations. So, what were some of the promising practices in South Africa? It wasn't all bad news. Certainly, there's been incredible innovation in the different settings, and just a few examples. So the community dialogues in the Northwest Province were very important in the implementation stages as an early initiator of ward-based outreach teams. They really took the lead in using that particular technique, and there was a lot of management support for it. In other sites like in Tshwane, I mentioned some of the studies that were done, but also development of additional resources such as the COPC practical guide that Tessa Marcus produced, which is really very, very comprehensive and a useful tool. And then intersectoral engagements. In some sites, there was a lot of initiative from community health workers to engage with social services, to engage with environmental health, to engage with other sectors as well. And then the development of digital tools. Quite a few of the sites, particularly those with university partners, developed apps for collecting the data. And even though, currently, in terms of the best quality evidence is still uncertain on the use of digital devices in primary health care, but local studies suggest that it is acceptable and it is promising in community health worker projects. But Feroz, in a review, also just gives a word of caution about some of the challenges that might be experienced by community health workers. Some other promising developments. It was clear that a lot of energy had gone into conducting implementation process evaluations in many of the sites, and with some really good implementation science approaches being used, and that sites were learning by doing, so a lot of organizational learning happening. There was also collaborations between the sites and with research and academic institutions who were really adding a lot of value to the process and to the quality of the research. Some concerns still about the quality and completeness of the data, and then also that very few evaluations of outcomes or impact have been conducted to date. Other promising developments, the huge concerns about the conditions of service and the turnover of community health workers has to some extent been addressed. There's now an agreement between the Bargaining Council, the Department of Health and unions about standardized remuneration of community health workers, and that they will eventually be integrated into the public health sector. So some other initiatives that community health workers contributed to during COVID-19, two projects in the Western Cape. First of all, involvement of community health workers in screening and testing, targeting vulnerable communities, but lots of challenges with the tools, logistics, safety and security, but definitely contributed to increased awareness in the communities. A project which had more demonstrated success was one which assisted with home deliveries of medication, so preventing chronic disease patients having to come into facilities and also decongesting facilities which were already overwhelmed with COVID patients. And, the community health workers working with the Central Medical Depot successfully delivered more than 800,000 medication parcels over a 6-month period. And the response from patients was that it was a better experience, and they reported better adherence to medication. This was also costed, and even though it had numerous teething problems, it was seen as a sustainable intervention which added value and improved the quality of care. And similar community health worker responses had occurred in a number of other countries. So it really shows the potential of these programs to be able to assist in responding in crisis situations like this. So I've just shown a number of projects there where they contributed to early detection of cases and contacts, health promotion. They integrated with the other activities and were able to show improved knowledge and practice in the communities and containing the spread. So what are some of the gaps and opportunities in South Africa? A lot of work has been done, and clearly there have been a lot of successes. Some of the gaps are around social determinants of health. The focus still seems to be on extension of care from the health facilities and health promotion around those, but very limited scope for addressing some of the underlying social determinants of health. And then governance of COPC. A few years ago, Uta Lehman and the late David Sanders provided a few scenarios for community health workers in terms of their location, either as part of the formal health sector or as part of or independent, and the pros and cons. So this really speaks to the governance at the end of the day. Who are they accountable to? And in our particular model, they are now located clearly within the public health sector, and the governance roles, responsibility and relationships within that arena need to be clarified. So the policy framework does outline what should be in place, and it'll be interesting to see how that actually pans out. Helen Schneider and Kumalo have published papers also looking at conceptual frameworks to really see how governance of these COPC projects can now be accommodated within the public sector where things tend to be a little bit more bureaucratic and rigid and where you need more flexibility. So it's really an evolving process. Other gaps and opportunities coming out of governance of COPC. There's a question of the links with community governance of health. So currently the COPC doesn't have any links with clinic committees, or there are no functioning clinical committees, or with local councillors. And this lack of relationships with community resources or integration with community resources has been critiqued by De Vries in a systematic review of community health worker programs. And on the basis that unless community health worker programs are integrated within the community, they cannot effectively operate and cannot be sustained. So it's a very important question there. And particularly if we're looking at this governance framework where really the links between the state and the providers in this triangle are very strong in the South African scenario. So the directives and the oversight and the resources come from the state in the blue circle at the top and go to the providers, and the providers basically report back and provide information. And there's very little linkage with citizens and clients through the other parts of the triangle. So that is a weakness in our system overall, and certainly so far integrating COPC into the public sector, that's becoming part of that weakness. And then the readiness of the health system to sustain COPC. So beyond the governance, the human resources, are our health professionals actually ready to support COPC as a major component of the health system, and what has been done to address it? And similarly, information systems, are we integrating that information? And then lastly, what are the effects of COPC on the health system? Is it going to ultimately improve the quality of care, and can it assist in improving transparency, accountability, and responsiveness? So I've really tried to take a health systems approach to COPC and seeing it as a complex adaptive system, so not just another program tacked onto the health service, but a really dynamic system which interacts with the rest of the health system and will affect it in ways which may be predictable but may also be unpredictable. And similarly, our health system will actually also impact on the existing community health worker programs in ways which we may not be able to foresee at the moment. So very important again for the COPC to be guided by the health systems framework so that we address all the components that are going to be interacting, and also take a whole of society approach. So it's not just about the health services, it's also about the community, and it's also about the other sectors, and how does COPC operate within that space. So a lot of potential for public health to contribute further. I know that tremendous work has been done in many of these sites by academics, by researchers, contributing to the development of the ward-based outreach teams. But certainly I think a lot of scope for ongoing work in leadership and management in the research areas, education of health professionals, and supporting collaborations across disciplines and sectors. So thank you very much.
Thank you so much, Lilian, and I hope we'll have you back online just now. I think we didn't give Lilian much of a brief in terms of the inaugural Pholela lecture, but I think she really captured what we had in mind, and I'd really like to thank her for that, and doing it under quite difficult circumstances. I think we can hear the symptoms there. I think, Hasha, if you don't mind, maybe we can just see if there are any questions, maybe just 5 minutes of Q&A, if anybody has any comments to make. Prof. Book. Let's take two, and it's Dr. Goldstein.
You know you're really going up in the world when Dr. Naledi delivers the mic to you. So, two quick points. The one is in terms of your presentation. So, I mean, in terms of Nandi's work, I think it just showed the potential impact that these can do. And I think, Saiendhra, in terms of your mission of the college, I think what we nearly need to work towards is a much louder voice for public health in the country that is visible, that is evident, and we've spoken about that before at PHASA as well, that our voice needs to be the first voice out there on public health issues and the go-to voice. And I think there's a strong potential for alignment between PHASA and the College of Public Health Medicine, and the sort of strong branding as well that the College of Public Health Medicine brings to it, together with the credibility of a broad public health association. And we all need to commit to building to that. Lilian, that was fantastic, as always. Just to say that I'd be doing my student and colleague, Professor Lena Thomas, a disservice if I didn't say that she graduated on Friday with a PhD on the effectiveness of community health workers in a Ekurhuleni district in Gauteng, and produced very good evidence on the effectiveness in terms of outcome and impact, both in terms of services as well as at the household level. So the publications are on their way, Lilian. So if you do an update next year at PHASA, you'll be able to show some of that evidence that you mentioned that's lacking about impact and outcome. Thanks.
Can we able to get Prof. Dudley on the screen?
Okay, thank you. Thanks very much for great talks. It's something that's worried me from the beginning of this discussion. There are two things that have worried me. The one is that the word communication has also not been mentioned in almost any of these talks at all. And I don't mean media communication. I don't mean the kind of communication that Eric's talking about. I know Eric has actually brought me into the field of communication in health, but really to communicate with people in communities it's just vanished off the agenda. And for me, I think that's one of the basic premises of public health, is to communicate together. And communication is not telling and sending messages. Communication is listening. And for me, it just shocks me every time I hear somebody talking that doesn't mention communication. And the second point I just want to quickly make is about multidisciplinary or interdisciplinary, I don't know what people call it these days. But and I'm a public health medicine specialist, one of the very older groups of people, but I kind of feel that we're doing a disservice to the community if we aren't working harder at pulling in other groups of people. Why aren't we pulling in more and more? We can't, I feel like we're closing in on the public health medicine group, and I think we should be going out towards other groups of people. So for me, that's I suppose it's an opportunity. Thanks.
Thank you. Lilian, do you want to comment on either of those comments?
Thank you very much for the comments. I don't think Eric's comment needs any kind of answer, but thank you very much. I'll definitely be looking out for the publications from that PhD. Really excited to hear about it. the comments from the last speaker, unfortunately I didn't catch her name. I agree with you that, communication in communities is certainly essential. And, maybe I didn't mention that in my presentation, but certainly I think in terms of the community engagement, it's implicit that part of that is listening and participating. And certainly in terms of governance, is having a say and having a voice in the decisions and the activities of health services. But yes, perhaps a bit more emphasis on the communication component would be needed. I'm not sure if I need to comment on the issue of multidisciplinary. I think in my presentation I made a point of speaking to public health practitioners as a broader group. I'm very aware of the fact that this is a session organized by the college, so there's clearly a focus around public health medicine in particular, but I agree that there needs to be collaboration with other practitioners within public health and also beyond public health. And certainly I think in the field, with the topic that I presented on in terms of COPC, we have seen our colleagues in family medicine also playing a very important role. And given that COPC is really that blend between public health and primary care, it certainly is an area that we should be collaborating on more. And certainly beyond that as well with other disciplines. But I think at the same time, for instance, some of the work that Virginia Siegenthal has published from her PhD does show that public health medicine has been very backward in coming forward. So doing a lot of work behind the scenes, but in fact not being visible. And that has meant that a lot of the expertise around the country has not been utilized because it's just not visible and hasn't been incorporated within the health system. So I do think, and I agree with Eric, that there is a place for making the work of public health medicine visible as well, so that it actually can play a much more prominent role in contributing to strengthening public health in the country as a whole. Thank you.
I have one, Dr. Naledi. I'm Erwin Friedman, and I'd like to reiterate what Eric has said, what Sue Goldstein has said. In fact, it's wonderful to be in the presence of some of the doyens and the stalwarts of public health. And also just to acknowledge some of the missing faces like David Sanders, who we miss terribly because he's been a champion in this area for so long. Lilian, that was really a remarkable synthesis over such a long period. I'm so proud to have worked with you, to have been part of your teams at relevant stages in the work. One of the elephants in the room that I picked up that is really going to be relevant even for what we're going to talk about now is NHI, universal healthcare, which of course is such an important part of what we've demonstrated through your work, that community health workers can make a very big contribution to, but they don't really figure in NHI at all. NHI, as we'll be talking about later today, is largely around health facilities and in-health facilities, unless I'm misreading it wrongly. The NHI bill is insufficient space to see the kind of benefit that community health workers and community-based programs can offer the health system in reducing morbidity, mortality, and obviously reducing the cost of healthcare. So it'd be interesting to hear your take on it, Lilian, how whether you do see that they are being incorporated in some way that we haven't seen before, whether this is something that we need to push for very much more in as we develop the NHI. Thank you.
Thank you very much. Wonderful presentation, Lilian. I just wanted to make a couple of comments arising from the presentation and from what Eric and Sue Goldstein said. sitting here as an observer of a conference like this, I wonder why it is that different disciplines in health work so much in silos. In the last couple of months, I've been to conferences of the Hospital Association, the Family Physicians Association. Across the road at the International Convention Center is the big TB conference going on. Here we are as the Public Health Conference. And whilst it's necessary for each of these tribes to talk to each other, there's also a desperate need for talking across these disciplines. And I would say to you as public health that there's a desperate need to put the imprint of public health on those other areas of health. And it's just not working like this. I mean, TB is such a public health issue, and yet all the activists are over at the TB conference, and very few of them are here. So how do we change that? And how do we, and Lilian's presentation in a sense exemplifies this. We've known the benefits of community-oriented primary healthcare since the days of the CARCs in the 1940s. Here we are in the 2020s, still trying to get what we know integral into health systems. And often we behave as if we have no memory, no institutional memories. So in the response to COVID, we acted as if we had learned nothing from HIV, particularly as in relation to communication, as Sue was saying, involvement of communities, not just telling communities, but listening to communities. And I just want to put this as a challenge to us, because I think, a conference like this would benefit from building bridges to communities. I think it would be great to have, in a conference like this, 20 or 30 people who are community health activists, who can just come and sit and absorb from your knowledge and your experience and take it back out there, but then become the advocates for the so-called public health community and these critical issues that you are discussing. So, sorry, that was a bit of a mouthful, but thank you.
Okay, thanks, Owen and Mark, for those comments. Lilian, do you want to respond and then just make a closing statement?
Thank you. Yeah, so thanks very much, Owen, for those comments, and I entirely agree with you. And the time constraints prevent me going into more details about universal health coverage and the NHI and the role of community health workers in achieving universal health coverage. But yes, definitely it is neglected in the current legislation and frameworks, and really need to look at how it gets a bigger role within the plans for the NHI. And clearly, I mean, where community health workers are already a quarter of the primary healthcare workforce, cannot be ignored. But unfortunately, I think a lot of the NHI policies, as you say, are focused first on financing mechanisms and then on facility-based care, and to a large extent ignored anything beyond facilities up till now. So we're now seeing some talk about social determinants of health, but still silent on the role of community and the role of community health workers. So definitely agree with you on that. And similarly with Mark, I think thanks very much for those comments, and I think you do remind us that at the end of the day, public health is about improving the health of communities, and unless there's a presence of communities in our debates and our discussions, we are missing out a very important voice. So I think that's possibly, I'm not on the PHASA exec any longer, but maybe that's a suggestion that the future PHASA conferences can take forward, and certainly in our practice, also just to be much more mindful as we continue planning our health systems. Thanks very much.
Thanks, Lilian. I think we're forced to end it at that at this point. And I want to thank colleagues, especially those that are not members of the College of Public Health Medicine, for attending our inaugural Pholela lecture. We hope to do this maybe once every 3 or 5 years at PHASA, but it is an annual lecture, and I'm sure through PHASA we will invite you every year to join us. So thanks again, colleagues. Enjoy the remainder of the conference.